Welcome, everyone. It's my pleasure to be speaking at this symposium, and I wish I could have been there in person, but I'm glad that there was this virtual option. It's really a pleasure to speak about this topic, artificial intelligence and endoscopy. It's time to up our game. My name is Jason Samarasena. I'm an interventional gastroenterologist at the University of California, Irvine, and we'll get started. These are my disclosures. So when I think about endoscopy and endoscope evolution, we can kind of go to the beginning where it started with this called the gastrocamera. And the next evolution was the fibroscope. And then eventually we got to the videoscope. And then eventually, we got to the more contemporary type of endoscopes, the high fidelity scopes, and now we have high definition as well. But as you can see, I really believe the clinical utility with better imaging really kind of plateaued. And now, we have these just incredible images that we can generate with our endoscopes. This is a high definition image with a near focus feature. And really, we're seeing just beautiful images of the mucosa of the GI tract. And I really believe that endoscopy has probably reached the limits of human visual capacity. I don't think putting any more pixels, in front of us is actually going to improve the clinical care that we can provide to our patients. So what's really next for endoscopy? And I think what's next is the growth and development of artificial intelligence. We see AI in our daily lives. Some of you may be fortunate enough to drive a car like a Tesla that relies on AI technology for semi-autonomous driving. But now there's been a lot of interest in incorporating artificial intelligence into medicine and specifically gastroenterology. But what is AI? And for those of you that are just sort of new to the field, AI refers to the ability of a computer to perform a task associated with intelligent beings. This is largely the ability to learn something. And actually, maybe more importantly, I would say it's an ability to predict something as it applies to our field. And there's a lot of terms that are associated with artificial intelligence. Some of them you see here, but this is sort of, I think, the most appropriate framework for what we deal with, which is a lot of computer vision algorithms in GI. So computer vision is a branch of computer science that leans on AI for augmenting our perception and interpretation of things we perceive visually. Within AI, there's machine learning, and then this is sort of a subset of machine learning called deep learning. With machine learning, you're really requiring criteria to be provided manually. Now, deep learning is the next evolution of machine learning. It can be supervised or unsupervised, and it's essentially automatically discovering and learning features to be used for classification. This is called feature extraction. And essentially, the computer is organizing these features with something called a convolutional neural network. At different layers, features or different aspects of features that are going to be looked at. Through this continuous learning, you're able to make a prediction about something that is seen visually. And this is much like the human brain. So in fact, neural networks are modeled and named after the biological nervous system of animals. So the visual cortex, for example, has an input via the retina. There's layers of neurons in the visual cortex. Some neurons detect edges, some detect shapes, some detect recognition of complex objects, but eventually at the output layer, objects are classified and then learned. So why is AI right for gastroenterology right now? Well, I think most of you will agree, GI doctors spend more time in front of a screen than really any other specialty in medicine. And also on that screen, we're seeing some beautifully crisp, high definition, high fidelity, and highly detailed images. Also, there's a lot more data. We have now large classified data sets with annotations. We have a lot more video data than we had before, thanks to video recording capabilities in a lot of our endosuites. And the other thing is, thanks to the video game industry, we have these really high performance graphics processing units or GPUs that can process large amounts of visual data in seconds. And speaking of visual data, I really feel that endoscopy is nothing more than really a silent stream of still images shot by a fast-clicking camera captured by a highly trained cameraman or camera woman. And also, when I think about endoscopy, I really think that high-quality endoscopy is a composite of three skills. One is understanding the biological, sociodemographic, and clinical factors surrounding that case. Two is really a technical expertise in the manipulation of the endoscope and the adjunctive instruments. And three is the real-time interpretation of the visual matter displayed on the screen. And I think GI fellowships do a great job with training us on one and two, but I think three is more difficult. And I think this is really where AI can help us. Because when I think about real-time interpretation during an endoscopy, say a screening endoscopy, it's really breaking that task into two tasks. One we can call red flagging, and two we can call characterization. So with red flagging, you're really looking to detect any areas of suspicion for a neoplasia or disease. With characterization, you found an area of suspicion, and then you're doing sort of this mental calculation of the probability of this being neoplasia. There may be people that see this patient with Barrett's esophagus, and they don't realize that this slightly depressed area that's kind of oozing is actually an intramucosal cancer that's depressed. Some might kind of blow past this area in the proximal esophagus and think that what they're seeing on the left side of the screen is just sort of schmutz and some food or something, and not realize that this is an early squamous cell carcinoma. And I know, for years, we've been doing colonoscopies, and, these sort of little patches of adherent stool, we didn't really pay much attention to them. And now we realize that, all these patches of adherent stool are probably a mucus cap over a serrated adenoma. And so our real-time interpretation, we are at probably different levels. What's nice is you can train a computer to do these tasks very, very effectively. For red flagging, that's called computer-assisted detection, or CAD-E. And for characterization, this is called computer-assisted diagnosis, or CAD-X. And so really what we're doing here is doing the endoscopy. All these hundreds and thousands of images are being processed by a computer in real time. And then that computer is going to predict something that's going to help us take care of that patient. So in this case, it's highlighting an area of possible early stomach cancer. And then based on, that information, we're making a treatment decision or a diagnostic decision for that patient in real time. And like I was saying before, the skill level for a specific endoscopic task is variable. There may be endoscopists that are very, very good. We'll call them experts, and endoscopists that aren't very, very good at all. And this variability in skill set is prevalent everywhere. But if you could take a bunch of experts and you could train an AI to do an endoscopic task, and then you could use that AI in real time, then potentially you could complement or elevate the skill set of those weaker performers to the level of the expert. And that's, I think, one of the most powerful things that I think AI may be able to do for us. And when that happens, this will lead to better clinical outcomes. So that was a little bit of introduction of AI and how it could fit into our field. But now I want to touch on a few of these key focus areas for artificial intelligence in gastroenterology. So AI in colonoscopy, the detection and removal of adenomatous polyps during colonoscopy, as we know, is the most effective way to decrease the incidence of mortality of colorectal cancer. And AI is particularly well suited for this endoscopic problem because it's large volume, it's image-based, it's very patternistic. And, the endoscopist's ability to detect polyps is really affected by things like fatigue, stress, level of experience, and AI algorithms can really support endoscopists, but it doesn't really get tired. It doesn't get stressed. It doesn't, change its level of experience once it's trained. So there's sort of 5 main areas in colonoscopy right now that has been the focus of artificial intelligence. One is pulp detection. And, originally, when these polyp spotters came out, there was sort of this non-localizing alert on the screen saying that, okay, there's a polyp somewhere on your screen. And then things got, a little bit better with a 2-monitor system where you could see a kind of a graphic put around the region of the polyp. But now we have this almost like classic green box that highlights a polyp. It's on one screen. This is sort of a bounding box being drawn like, many, many times a second to really localize where that polyp is. So do these polyp spotters work? Well, this was a meta-analysis that we presented at DDW this year. And we split up the meta-analysis into non-tandem studies and tandem studies. And with the non-tandem studies, we saw a pooled increased adenoma detection rate of 58%. With tandem study, it was about 36%, but still significant. And with tandem studies, as you know, you can calculate something called miss rate. And with AI enhancement, there was a 33% lower adenoma miss rate with these tandem colonoscopy studies. Another idea is using AI to aid the endoscopist to perform colonoscopy with a higher quality technique. So while withdrawal time we know is a good target for AI algorithm development because it's an important indicator of quality in colonoscopy guidelines, we know that a rapid withdrawal will reduce endoscopic stability, it'll increase the risk of missing polyps. And so this is a study looking at an algorithm called EndoAngel that was really essentially a speedometer for colonoscopy. And it did this by assessing previously seen frames, calculating similarity of consecutive frames to calculate essentially a withdrawal speed. And there was a system output as a visual and auditory warning for slippage and rapid withdrawal. And as you might expect, with the EndoAngel system on, the withdrawal times were higher, adenoma detection rates were higher, and polyp detection rates were higher. Now, this is another idea of combining multiple AI modalities to improve quality. So in this case, the AQCS algorithm had multiple algorithms happening at the same time. It was able to recognize blurry frames and consecutive frame similarity for that kind of speedometer type feature. It also assessed mucosal visibility. It also had a colorectal polyp detector. And then it also gave an audio prompt for a Boston bowel preparation score less than 2. With all of these algorithms performing simultaneously, they found the withdrawal time was longer. There was improved adequate bowel preparation rate. There's an improved ADR. So when I see something like this, a system that's sort of cohesive, multiple algorithms running at the same time to improve colonoscopy quality, I think, this may be the future. Now, the reasons why we might miss a polyp is because, one, it wasn't in the field of view, because that area of mucosal surface wasn't really examined well. And sometimes, it is in the field of view, but it wasn't really recognized by the endoscopist. So I think these colon polyp spotters will do a good job there. But if it was never presented in the field of view, well, then there's really no way to catch it. And so this is a new technology that a friend of mine, Dr. Thakkar, is working on. And in this video, you can see he split up the colon into sort of top left, top right, bottom left, bottom right. And as you inspect more of that, say, quadrant, the dark green turns to a light green of that quadrant. And so in this case, you can see the bottom left hasn't been inspected very, very well. You're spending more time now in the bottom left quadrant. And as you do that, the dark green is turning to a light green. And then basically that segment now is completed, and you can sort of, keep moving backwards, in your withdrawal phase. So this is almost giving you instantaneous feedback about how well the mucosal surface is being visualized. So this concept of mucosal surface area tracking. And what you get essentially is a fingerprint, a digital fingerprint of how that colonoscopy went and how you performed. And so again, this is using AI to provide almost quantification of the mucosal exam to kind of push us to doing the best quality exam. Another area of interest for many, many years has been this sort of concept of optical diagnosis. Can we predict based on the surface pattern if this polyp is a hyperplastic polyp or something that's clinically significant, some type of adenomatous polyp? And basically this is ripe for CADX or computer assisted diagnosis. And there's been a lot of studies now looking at the ability of AI to do essentially optical in vivo histology of colon polyps. And it looks like the AI appears to be performing better than the endoscopist. And now, actually in Europe right now, the latest iteration of the GI Genius has this CADX feature. One of the things that I think a lot of physicians would love to have is an AI algorithm watching your colonoscopy procedure, taking notes, and then basically doing the report for you. This has the potential to avoid errors, improve efficiency, and potentially minimize clicks and screen time for the endoscopist. And this is something that Dr. Bill Carnes at UC Irvine, my colleague, has been really busy working on. Basically, multiple algorithms need to be running simultaneously for this to happen. We need a Pulp Detector, something that does optical path, landmark recognition, prep quantification, needs to be able to assess tools, and polyp size and morphology. And hopefully, one day, things will look something like this, where, we do our colonoscopy, it records our in time, it records the time that we get to the cecum, it's assessing the quality of the bowel prep. In that case, it was really bad. Then the AI polyp detector is helping us detect polyps. It's doing basically characterization of the polyps. In this case, it's a serrated polyp. It's detecting a snare tool is being used to remove this polyp. Algorithms that can detect multiple polyps simultaneously and do characterization simultaneously would be ideal. And eventually the AI marks when the scope is out, and then essentially taking kind of all this information and then populating the report so that once you kind of leave the procedure room, go back to your computer, it's essentially all there. You would just sort of fix a few things and then sign off on it. This is sort of the goal. So you can almost imagine your AI has assisted you in performing the exam with a polyp spotter technology, a withdrawal speedometer, a mucosal surface mapping tool, and AI has recorded all the quality metrics: cecal intubation time, withdrawal time, prep quality, calculated the ADR. And now AI has completed the colonoscopy report. It's auto-labeled images, including cecum. It's given you accurate diagnostic and procedure codes. It's given you guideline surveillance recommendations. Your job is to simply review, edit, and sign. And the AI is constantly learning and educating itself based on the feedback that you're giving it. And I think this is coming to us soon, probably sooner than we all think. The last topic I'm going to touch on, just because we're a little short on time today, is Barrett's esophagus. So one of the things that we set out to do is to see if we could have a computer-assisted diagnosis algorithm that could find dysplasia within Barrett's esophagus. And I've shown a lot of folks this video without the AI being turned on, and it takes some time for people to realize that essentially all this area that the algorithm is highlighting is actually dysplasia. And so we've done a lot of work in this area to try and create an algorithm that can provide a continuous real-time AI assistance during a Barrett surveillance procedure to locate and even grade kind of the level of neoplasia within a Barrett segment. And so last year at DDW, we did our external validation study using pre-recorded videos. We got 40 video clips from 40 unique patients from 2 outside institutions, and 20 patients had at least one dysplastic lesion, and 20 patients had no dysplasia. The videos were reviewed and timestamped by 2 expert endoscopists where they identified dysplasia, and we scored each lesion on a scale of subtlety from S1 to S5. And so the algorithm actually did a very nice job. It detected 19 out of 20 lesions, so a 95% per lesion sensitivity. In the non-dysplastic videos, there was some kind of flickering of boxes, so we call those false positive, and about the false positive rate was about 3.7%. But none of these boxes really hung on for the requisite 3 seconds in this study to be called technically a false positive clinical prediction. So those 0 false positive clinical predictions, and the per patient negative predictive value was 100%. So encouraging results. Others have worked on this as well. This was the first live endoscopy pilot on Barrett's esophagus and dysplasia detection. This was 10 patients with non-dysplastic Barrett's and 10 patients with confirmed Barrett's neoplasia, a study done by Dr. Jacques Bergman's group in the Netherlands. And in this algorithm, essentially, you kind of walked up the Barrett segment and you took a freeze frame. You'd freeze it, you'd wait for the algorithm to give you a prediction, you'd unfreeze it, freeze it again, wait for the algorithm to give you a prediction, unfreeze it, freeze it again, and then based on those 3 predictions, you would make a judgment of whether there was dysplasia at that level or not. And overall, the per level analysis of the system was very good. Accuracy 90%, sensitivity 91%, specificity 89%. And so again, these are very encouraging results as we see this field develop. Lots of things happening in artificial intelligence and gastroenterology, and I only really hit on a couple of things. I think high definition endoscopy has reached the limits of our human visual capacity. Real-time interpretation of the visual matter is really where endoscopists need help. And I think computer vision algorithms really fill this need well. The progress in AI computer vision development is really exploding for neoplasia detection and characterization, and also endoscopy quality improvement as well. Now we're getting to the stage where there's a lot of live prospective real-time studies. Before it was really just kind of studies on still images, then studies on kind of videos, but now we're really seeing these live prospective human real-time studies. And I think there will come a day when AI will serve as kind of the virtual expert in the endoscopy room, guiding us through the exam. But right now, a lot of these algorithms are made by different companies or made in different countries. And I think the challenge will be integrating multiple algorithms on a single platform for us kind of all to use. And I think that's when that happens, we're really going to be making headway. And then that's really when we'll take our game to the next level. Thanks very much.